lipid bilayer, so they understand what the fat is and why.
Yep.
So, yeah.
And then Dom, any slides that you need up, just email me right now too, and I can.
Did you get the 3 that I sent yesterday?
I have those.
And then the only other thing I would add, Dan, is that Raskow graph that was distributed yesterday from Raskow showing the demand in our area still.
Oh, okay. All right.
All right.
Second here. All right, here we go. Saving change. Can't tell if we're up yet, but it looks like we are. So
we see a little meter ticking says we're 45 seconds in.
Yeah, good deal. We are up and running, so I think we'll kind of take it from there.
All right.
Welcome everybody tonight. I am going to let people self-introduce. We're going to let some people kind of pile on here. We were about 1 minute late getting live, so that's on the tech guy here, trying to run some fancy stuff for everybody here so that we can interact a little bit better with you guys. So at some point or another, for those that you can see the StreamYard thing down here where it says click to comment, or whatever, we will have the ability to see your comments and respond to some of those as we go here. So some destinations don't get comments, some do, but most of you that are on Facebook or YouTube should be able to just fine once things are all up and running. So from that standpoint, we are also going to, PJ, I think I'll just turn it over to you to kind of introduce everybody and welcome everybody. And I'm going to kind of bounce Tom and I out of here for a little bit. So thanks for everybody for showing up tonight. I'm really, really stoked that these professionals would take this time with us again. Last week was a lot of fun. Hopefully you have a drink or something like that that you can, have to refresh yourself while you're getting this information. We are going to be talking about some serious things, and certainly we can answer some serious questions, but we're just trying to have a laid back conversation here. So
yeah,
thanks for everybody for showing up, and take it away, PJ.
All right. Well, thank you. And thank you, Dan, for coordinating this. And I'm not sure if everyone knows my connection with Dan. Dan he owns several Remaxes in the area. And I was connected to him through my son, Dominic. And we were doing Wellness Wednesdays at Remax on Monona Drive for several months. And our Wellness Wednesdays have turned into Pandemic Wednesdays. And we just thought it'd be really cool to kind of give like news from the backyard and talk to doctors and nurses from all over and take a break. And it's a casual sort of town hall talk. And last time we met, we talked about ways to boost the immune system and went over some safety tips for that time. And, that's 2 weeks ago. But I first would like to welcome Dr. Michael Eisen. He is a Northwestern professor in Division of Infectious Disease and Organ Transplantation doctor. He's an infectious disease doctor. So we're happy to have Mike here, and he has some slides with us. And then this is Dr. Mac DeCamp, my husband. He's chair of cardiothoracic surgery at UW. So everybody's going to take turns. And my background is nursing, and I have a master's in healthcare quality and patient safety. And I'm the founder of Field Garden. I do health coaching these days. So we're going to start with Michael. And a big cheers to your mom and dad. I know they're watching us, and family and friends. So thank you, everyone, for joining us.
Great. Well, thank you. So my name is Mike Eisen, and I'm an infectious disease doctor that's historically focused on respiratory viruses like flu and other respiratory viruses in adults. So clearly this is an unfortunate pandemic, but one that I'm very interested in from a research standpoint. So I thought I would start for a few minutes just going through a couple of simple slides to give you just some background, some information, including some data on how we're doing in terms of flattening the curve, which I think is something that everyone's focused on since they're stuck at home. Next slide. My disclosures. You can move on to the next slide. So over the next couple of minutes, we'll talk a little bit about the virology, how we're doing in flattening the curve, and then prevention and management options. Next slide. So coronavirus is a very common virus, although this novel virus is new to humans. Human coronaviruses, most adults get 1 to 2 a year. They cause the common cold, and so generally people don't get terribly sick from these viruses. But there are some animal coronaviruses, SARS from 2002, MERS from 2012, and now the new SARS-CoV-2 or COVID-19 that have emerged from animals and infected humans, oftentimes with severe illness and high rates of death. The nice thing about this virus is that we're very lucky that it's an envelope virus. It has this lipid bilayer where there's lipid between the surface of the virus and the RNA that makes up the core of this virus. And the reason why that's important is because that allows us to inactivate the virus by washing our hands or using alcohol hand gel to basically prevent the virus from infecting one another. Next slide. So as we know, COVID-19 really has affected the entire world. In fact, there's disease on every continent except for Antarctica. Shown here in the yellow as of a couple of days ago were countries that had a significant increasing rate. Unfortunately, the United States, as we all know, is still gold for increasing levels. Next slide. And then this is looking at the US data with sort of a heat map over the areas that have large number of cases. Clearly, New York has the most cases, but we have other areas like here in Chicago that are not too far behind, especially in terms of the upswing in infections. Next slide. One a way to look at COVID-19 and understand how we're doing in terms of flattening is to look at mortality. And unfortunately, this is the slide for various countries. And you can see when they start curving to a flatter level, that's a sign that we're gaining control. Unfortunately, the United States is still relatively straight and going up, although it's starting to curve. So hopefully we're getting to a point where we're going to start gaining control. Next slide. We've learned a lot about this virus and things have moved very quick. I think most of us find it hard to believe that the first patient with COVID-19 was identified December 8th, although not recognized by doctors as a clinical syndrome until the end of December. Just shortly after the cluster was found, the virus was identified through sequencing in China, and then confirmed human-to-human transmission was documented just a few weeks later. Since then, things have spiraled so that we now have a pandemic that was formally declared on March 11th, just a few months ago, just a little over a month ago. Next slide. So many times people wonder about the range of illness, and one of the challenges that we have is that we don't really understand what proportion of this pyramid is the fact of what people are experiencing. We generally aren't doing a lot of testing, so we suspect that asymptomatic cases are representing a relatively small proportion of patients with this disease. Although with more and more data, it's looking like it's somewhere between 25 to 50% of patients have asymptomatic disease. Thankfully, severe cases and those that die are still a relatively small minority. Only about 15% of patients have what are defined as severe disease, with fatal cases really only occurring somewhere between 1 and 5%, depending on the country and capacity in the area. Next slide. Part of this is driven by our testing methodology, and so this is showing two different countries. Germany, which is generally only testing patients that have symptoms, compared to the data for the UK that really is only testing patients that are in the hospital. And as a sense, you can capture, because of this different testing, you may get a different picture. The UK, the mortality looks much higher, but part of this is just because they're testing a smaller proportion of the patients that actually have disease. Whereas if you test even more of the population, you'll see that the mortality rate is actually a little bit lower, but that's just because you're detecting more of the patients that have mild or less symptomatic disease. Next slide. The general clinical course of disease in patients, typically the patients have respiratory tract symptoms, usually a cough. They then begin having fevers that may be very high. And then as you get close to day 7 through day 10, people may develop shortness of breath, which is a real symptom that raises a lot of concerns and generally means that people have to go to the hospital. This shortness of breath can last for up to 10 days, particularly in patients that require hospitalization. As the fever goes away, patients begin feeling a little bit better, with residual fatigue lasting for a longer period of time. Next slide. This is just showing some information on time to progression. So from the time when a person becomes initially infected to starting to have symptoms is somewhere around 7 days. Until they get sick enough, if they're going to become sick enough to need hospitalization, is typically at around day 9. And patients that get really sick in the hospital and need ICU level care typically do this between day 10 and 14. Next slide. There have been a number of studies, this is just one from China, that shows what risk factors we've identified. From China, we know that common conditions such as diabetes or hypertension are 2 of the most significant risk factors for patients having more severe disease. And the reason why I highlight this is that many people will feel that they are healthy, but they have mild hypertension. But it is important to recognize that this is one of the more common risk factors, and this has persisted in Italy and US data. 2 factors that have emerged in the United States as evidence of a disease that is more likely to progress is when patients are obese, particularly those that are morbidly obese, and minorities, particularly African American and Hispanic minorities, are more likely to have risk of hospitalization, ICU level care, and death. Next slide. This is, again, just kind of running through the common symptoms. Typically, they start with a fever, dry cough, and fatigue. They can get worse in patients that have very high fever, and we're seeing temperatures up to 103 through 105. Patients that start coughing and having blood in their cough, and then those that have lab evidence of low white blood cell counts are those that are more likely to progress to needing hospitalization and ICU level care. Next slide. I'm going to go past this next slide. So in terms of risk of death, clearly the one feature that has come out in all of the regions is that older adults are clearly at higher risk of getting severely ill and dying. This is particularly true when you start going above 60 years of age. And as you get up to 80 years of age, mortality can be as high as 15 to 22%, depending on the country. So again, this is why it's important, even if you're young, to make sure that you're still distancing yourself and keeping yourself healthy, so that when you go to visit grandma or your parents, you're not making them sick. Next slide. This is a little bit of the data that from here in Chicago and New York, showing that minorities, particularly Hispanic and African Americans, have a disproportionate incidence of disease and mortality. Next slide. So there's a lot of discussion about whether or not this virus is airborne, whether it's something that we can easily transmit. And what we have clearly shown through data is, although there are certain things that can generate aerosols and put patients at risk of spreading the virus through aerosol, meaning that it can easily spread and stay in the air for a prolonged period of time, the reality is that if you look at other viral infections like measles or chickenpox that are truly aerosol transmitted, they tend to result in far more infections per index case or individuals with infection than we're seeing with this infection, suggesting what most people feel, that droplet transmission, meaning small droplets that can be transmitted over a relatively short distance and can be protected with the use of things like masks, is probably the predominant mode of transmission. We also, I think, can look back historically, just a few months ago, at the first estimates of what the first wave of the COVID-19 epidemic was going to do in the United States. It was estimated that there would be about nearly 100 million cases, about 4.5 million hospital admissions, and somewhere between 0.5 and 2 million cases of fatal disease, which clearly is much worse than you would see with influenza. Next slide. But thankfully, we've done a good job of flattening the curve. Everyone's kind of heard about the issue of flattening the curve. And what this does is two things. It really reduces the peak of the number of cases that we're seeing. And the goal of this is to bring it down to a level where you don't overwhelm the healthcare systems, as we saw in New York City. The downside is that it means that the amount of time that the virus is circulating and there's risk is lengthened relatively significantly. And so that's what we're starting to see now. We've definitely seen in most areas that we're not overcoming the healthcare systems, but it means that we're going to have the virus around with us for a longer period of time. Next slide. And there's really some clear data. The best is shown in the lower right-hand side of this graph, which is data from Seattle. The kind of orangey yellow squiggle there is showing data from Facebook, which shows where people are checking in. And the more often they check in the same location, meaning that they're staying at home, the lower that yellow bar gets. And what you can see is as the more and more people were staying at home, getting close to that one mark where basically they're in the same location every time for multiple days, you see that the black dot's going down, and that's the number of secondary transmissions that you're seeing for every index case that is identified, suggesting that this social distancing really is doing a good job at reducing the transmission rate and overall flattening the curve, as we've been talking about. Next slide. These are just some predictions. I'm going to skip through this in the interest of time. So the last two slides are really to talk about vaccines. Thankfully, we've made a lot of progress, and there's now at least 3 vaccines that are aggressively moving forward, as well as a handful of other vaccines that will be following shortly behind. The reality is this is going to take time. We're not going to have a vaccine by the end of summer. More like in a year to 18 months, we'll have a vaccine that's hopefully safe and effective. Things could slow this down if we start seeing safety signals or other issues that come up, and things could speed things up. If there's a blockbuster with no safety signals, the approval process may move a little bit more quickly. Next slide. There's a lot of work ongoing looking at novel treatments for SARS-CoV-2 or COVID-19. Many of these are really focused on the immune response to the virus, but there are a number of drugs that are being developed specifically to fight the virus itself. We definitely need more of these drugs to slow the replication of the virus, similar to the drugs that we have to treat flu, so that we don't have to use these salvage therapies when people are very, very sick. So that's all I was going to talk about today. I'll turn it back over to PJ to move us through to the next stage.
So we're going to have a question session at the end, but I did want to touch base on a couple of things that you mentioned. Is this still affecting males more than females and a certain blood type, like blood type A? Are we still seeing those types of results?
Yeah, so blood type is one that people haven't looked at as closely. The group that's looking at blood typing, we added that to our data mart that we're trying to look at. So I can't really specifically comment on that. There's definitely a male predominance. So somewhere between 60 and 65% of the cases are men. And if you look at patients in the ICU, it's even higher, typically around 75% of the patients in the ICU are male.
Wow, but we just don't know why that is yet, right? Because we're in the thick of it.
Yeah. And I think there's a lot of work. There's a big project that's going on where they're doing sequencing of all the genes in patients to see if there's certain things that are turned on, turned off that may be risk factors for this, and maybe the more common in men than in women.
Well, speaking as a male over 60 with blood type A, and my wife wants to put me in a cage, not subject to the Tiger King.
But he may look like the Tiger King soon. I got clippers.
Yeah, she's going to cut my hair.
Look out.
She's done with him. I'll send
mullet.
So Dan wanted some levity, so there's some levity. Mike, I just wanted to go back to some of the comments about the racial disparities in how this disease is affecting, both African Americans and Hispanic populations, and hopefully dispel a rumor that it's not that they're necessarily more susceptible, that they're the rates of obesity, hypertension, and some of these other comorbidities are higher in those populations. The places where they've been more adversely affected, they're more densely populated, and they have, we all know they have less access to healthcare, both maintenance healthcare. So I don't want folks listening to think that they're necessarily more susceptible. I don't think this virus discriminates that much. We honestly don't know the denominator. As you pointed out, we don't know how many asymptomatic or minimally symptomatic folks are out there who actually have had the disease or who are carrying it. And that's the whole rationale for social distancing. But they are disproportionately affected should they get disease.
Yeah.
So I think that's an important distinction, rather than to say that blacks or Hispanics are at a higher risk to get the disease.
Correct. And there's other things that go along with it. We had someone that was talking about the impact on Africans, which is a big problem here in Chicago with this disease, and it also has to do with there's more essential workers that are African American doing certain jobs that are directly facing out to the public, and so that also contributes to probably increased likelihood that they're getting exposed.
Yeah, it's certainly not fair, and it's one of the reasons where we're seeing a high amount of disease in Detroit and Chicago and Louisiana, in addition to New York.
So, Mike, I found this really interesting graph. I should have sent it to Dan, but I didn't. It was a Reuters graph, and they showed MERS, SARS, and the coronavirus. And for every 50 people that were infected, 17 MERS died, 5 people with SARS died, and 1 person with coronavirus died. I thought that was so interesting because the fatality, when you compare the three, coronavirus is much less, but the communicable part, the disease, how catchy it is, how fast it spreads is way off the chart compared to the other two. So
I think part of that too is that if you look at the clinical course of disease, it's very different. So almost all patients with SARS and MERS had symptomatic disease, whereas we know that there's a sizable proportion of asymptomatic patients. So that just facilitates kind of silent transmission. The other thing that is really important to recognize is that the time frame was also different. When people got infected to when they got sick was just a matter of days, whereas for this, it's almost a week before people start getting sick. And so if you add to the fact that they have this longer incubation period till they're clinically symptomatic, added to a larger asymptomatic proportion of the disease, you're able to spread the disease much more quickly, and also it's much harder to get control of this virus for it. And then thankfully, the mortality is much lower than those viruses, because if it was at the SARS, which is about 9% mortality, and MERS, which was 30% mortality, we'd be talking about a very different situation.
So Mike, we have a basic question here. Is social distancing really working, and should we stay the course? When do you think life's going to return back to normal? Again, we're going to have the questions at the end too, but some are just popping up now, so we might as well just go with it.
Well, what I would say is social distancing is definitely working. So if you look at the original case estimates, we were talking about 100 million patients. And granted, we've got still another month to go, but our current global number of cases is just over 2 million. In the United States, 636,000. So far less than the 100 million that we would have been expecting just for the United States alone. Likewise, mortality is, instead of being 1 to 2 million people, is going to be closer to the 30 to 50 to 80 million. So what we've done is it's working. We're having much less of an impact, and thankfully, that what we really wanted to accomplish is that the hospitals aren't being overwhelmed. They were in New York. Thankfully, so far, here in Chicago, things are under control, and we're able to control. When will life return to normal? That's the million-dollar question.
Yeah.
I think the big challenge is since we flattened the curve, it also means that things are going to splay out. So I suspect we're going to see a lot of disease and probably have an impact on our lives for most areas through much of May. It's going to be very different for different parts of the country. If you're in a more rural area where it's easier to social distance, it may be something where you can get to back to normal sooner. Here in a big city, it's going to be a lot harder.
So, Mike, I think I know what you meant, because Mike and I worked together for 9 years. I think you slipped out a number there about deaths in the millions, and right now, even worldwide, we're talking about 133,000 deaths. So we're blessed. We think that the impact of the case fatality rate is going to be far less than we had feared initially.
Yeah.
I don't want people walking away from this chat thinking that there are going to be millions of deaths.
I think he was talking about the model that was projecting early on.
Sure.
So how are things looking in Chicago? And, were you worried at any point that might be the next New York, being that it's a large city?
Yeah, I definitely would say if you looked at, so we truly had exponential growth of cases as of about a week ago, and pretty much everyone was very worried that as of last weekend, when we would hit a point where we would basically max out our hospital. Mm-hmm. Thankfully, that hasn't been the case. We have plenty of ICU beds, plenty of hospital beds to take care of patients. Some of the smaller hospitals are having a hard time keeping up, but for the most part, we're pretty lucky that we've got good capacity, and our mayor's done a great job too of reinforcing stay at home.
There was a funny meme with your mayor, and it was on Easter Sunday, and Jesus was trying to come out of the tomb. He rose from the dead, and she was standing there, and she's like, "No." I thought that was hilarious. With a very stern, face. It was so funny. But all right, so we're gonna give you a break, but jump in anytime, and we're gonna let Mac take over a little bit. And again, we have a bunch of questions for you at the end as well. Okay. And yeah. So Mac, you're going to fill us in with what's going on at UW. There's some great things going on at many hospitals across the country. We're so excited about wonderful things, as far as testing and equipment and such. But we thought we'd bring this home, and you can talk about what you're doing. And we even have a couple of pictures of Mac with his PPE on that Dan's going to pull up in a second.
Well, we're very proud of the collaborative efforts that have gone into the planning that we've been fortunate enough to have the time to do here in Wisconsin. So we've been able to, with social media and the way we're all connected around the world now, learn from our colleagues. We literally, between all the WhatsApp groups, chat groups, and things that we're all in professionally, we can really share experiences around the globe, which has been fantastic. Within the University of Wisconsin environment.
Here's what I found.
We've been very happy to have these collaborations with our engineers, who immediately went out with very little, provocation and started to 3D print face shields for all of us. They've even gone on to modify the face shields we use in the operating room that allow us to use our magnifying surgical loops and our headlights and our microscopes, but still allow us to protect ourselves and our operative teams. So we're very grateful for the whole group of folks in academia who really come to the to the rescue. And this isn't just happening here in Wisconsin, it's happening across the country, but I've been a personal benefactor of what's going on here. We do have some pictures. You guys hear all the time about PPE, and you see pictures on the news. I don't know if Dan can put up.
Can show you
So-
the picture.
All right, here comes the photo of the day.
Woo, woo.
So we have a standard PPE. That's my N95 respirator. That's my mask that I get to keep now and use every day for anybody who's either COVID positive or a person under investigation. It's an incredibly uncomfortable thing to wear all the time because it's designed to prevent transmission of very small particles to and from my respiratory tract to others and others people's to me. But it creates muffled voices and mumbling, and it's challenging to understand. And I can guarantee you, operating for 3 or 4 hours with one of those on is not a lot of fun. Now you can see the face shields. They all look the same now. That's the problem with 3D printing. They're excellent at producing exactly the same thing. So we all have to put our names on everything. We carry around plastic and paper bags that we carry these things in between cases and wipe them down and trying to preserve PPE, because that's been the biggest issue for us and for what happened to our colleagues in New York, places in Italy that got overrun, is that they quickly ran out of PPE, and that puts the healthcare workers at risk. And then you have the healthcare workers getting sick, and so you have a double whammy of socially disseminated disease with exponential growth of patients showing up at the healthcare facility and exponential decline in available qualified people to take care of them. So we've been fortunate to be able to use our PPE carefully and not exhaust it. And with the flattening of the curve, we're quite comfortable now that we're going to have enough to go around to take care of the patients that need us for the weeks and a couple of months, I'm afraid, to come.
I have a comment. So these masks were made by the UW engineers, and they sent
The face shields.
The face shields, I'm sorry. And they sent this design all over globally. It's just so cool how people are coming together to work on these. I have a question for you. So you have your N95 mask on, you have glasses on that's protecting your eyes. Why would you wear a face shield?
Well, you can have splash and splatter that can go in and around things. So especially this is what we would wear in surgery.
Mm-hmm.
So it's basic protection. And folks that don't wear glasses, I wear glasses so I can see straight. Other people don't need to wear glasses or wear contacts. We can talk about contacts in a minute. Mike might have some opinions about that, because that gets you touching your eyes, which is another way of infecting yourself. But the face shield is, it originated with OSHA and things like that to protect us, not only full face, but on the side. So this wraps around and all the way back to our ears to keep us from getting splashed.
Does it also prevent you from touching your face after?
It makes it, it reminds you not to touch your face. Yeah. But in surgery, over time you learn not to reach up and touch your face because you're supposed to be maintaining sterility. Now the other thing that has been helpful in us preserving PPE is the ability to test, and the way that we've been able to stand up rapid testing around the country. And that's got a whole interesting timeline that maybe some other time we could get into, in terms of initially we had to use the WHO or the CDC guidelines, and this was only available in the state labs, and there was minimal reagents, and it took 3 days to get results. And that clearly wasn't going to be an adequate way to respond to the overwhelming patient load, so that the regulations were changed and institutions were allowed to come up with their own testing platforms. And University of Wisconsin was one of those places that came up with that. And we were able to institute testing within a couple of weeks on our own, and then increase the throughput of that testing. We had initially just a system that you had to have at least 30 tests ready to go. It was a single plate. You had to fill all 30 wells in the plate, and then you could run the test. And there was a 12 to 16, 18-hour turnaround. Now we have single ability to test patients even quicker with a turnaround time of 6 to 8 hours, and And now even in the last 2 days, we've been able to come up with some point of care testing. There are 2 products out there these are all PCR tests that look for actual viral RNA in the sample from the nasopharynx. And Mike's more of an expert about that than I, but it detects a single strand of RNA. So it'll detect patients that have a viral load in their nasopharynx. And now with these point of care tests, we can do this, for example, in an emergency room, get an answer in 45 minutes. And if you need an emergency operation, then we know whether we need to wear that PPE or not. In the last 3 weeks prior to this, we just wore PPE presumptively, and we're consuming a lot of PPE in that situation. So now that we know, it's nicer for the surgeon and the whole surgical team if we know they're COVID negative in the emergency room, that we can wear our standard protective stuff and not start to consume this valuable resource. Same issue applies to ventilators. By flattening the curve, we've been able to avoid the rash of patients that need to go onto mechanical ventilation. And as Mike showed some of the slides, we think we have the capacity to weather the storm. The problem is the storm's going to last for several more weeks before we're on the backside of this.
But we're going to get through this.
We are going to get through
We had a question come in actually that got texted to me. Sorry.
Okay. Yeah.
I just think it's pretty valid, or interesting. But for you guys, what is the most surprising fact about this particular virus in your guys' medical histories? What's the most surprising one that you guys have seen, or the most surprising part of it?
I'll say from my standpoint, I think the thing that is the biggest surprise is how everyone, at least in the medical world, and I think it's true everywhere, is absolutely focused on fighting this. And so, I think as Mac was talking about, you have, the engineers and the people who print things. I don't know how to do that, but they're figuring out solutions for this. I have calls every day from urologists and whatnot that have ideas about how to be creative and solve real-time problems. I think that's been really exciting to see.
I have to echo Mike's sentiments there. We very quickly, because of social distancing, shut down research and all the things going on in the university. Yet a lot of these researchers had laboratories that worked on RNA and DNA and had reagents that we were lacking to be able to do more testing. And overnight, we would have, cartons of reagents delivered to the clinical lab to be used to allow us to increase the throughput of testing. So it was quite amazing how people pitched in, and even in the community, they're reaching out to ask people to make masks or provide daycare for the healthcare workers. So it was really quite amazing to see how all walks of life pitched in. On the medicine side, talking to my peers that are on the front lines in the ICU, when these patients get really sick in the ICU, they get really sick in a hurry. And, it's a little bit different, the pace of their decline, than what we're used to seeing with other forms of something called ARDS, the adult respiratory distress syndrome. The COVID patients decline in a big hurry. So we've had to stand up ICU teams that have enough capacity to deal with a lot of sick patients in a hurry.
And then do you want to talk about the UW?
Yeah, and Mike will weigh in on this. He talked a little bit about vaccine, and a vaccine's, I think arguably a year away. And it's hard to figure out how to raise the vaccine that's going to be truly effective. I've had 2 of my colleagues who've had the disease and have recovered, fortunately. And, I jokingly said, I want some of your plasma, tomorrow, to make me feel safe and to go into the hospital. But UW is part of a multi-institutional clinical trial using convalescent plasma from coronavirus patients who've recovered, in a collaboration between all these institutions and the Red Cross, to give this convalescent plasma as therapy, because presumably this convalescent plasma has the actual antibodies, neutralizing antibodies, that would be potentially the most effective therapy. So I'm going to get out on the thin ice if I keep going on that. I'm gonna let Mike, who knows a lot more about this stuff, talk.
No. I think it's really important. We're involved in that study as well here at Northwestern. The big challenge that we're having is that so there's a requirement, so people have to be 28 days recovered before they can donate the plasma. And so, if you think about that, we're about 3 weeks or so into the kind of the big bloom of patients we saw in the United States. There aren't a lot of people that have fully recovered. But I think if you have, if you're watching this and you had COVID-19 and have recovered, I think the best thing you can do if you want to help is to look on the website for the American Red Cross or your local blood bank, and they will have information about how to donate plasma. And then while I'm plugging that, there's a need for all the blood products. There aren't as many people going to get blood drawn. They're set up so that they're safe. You're not going to get COVID by donating blood, but it's going to help multiple people by doing so. And like I said, the plasma will help, and I think is now one of the most promising therapies.
Yeah, that's awesome. And if we are able to develop testing that we can use more widely, we may find that there are a lot of minimally or asymptomatic patients that have convalescent plasma and don't even realize it. So again, as we get through the rest of this year, we can scale up the ability to understand what the true denominator of infected people is.
I just saw UW looking for folks now to test to see if they've had it. Maybe they really don't know. I don't know if UW is, but there are studies out there where they are collecting samples. Mike just posted some today, and there was another. I'll get back to you with which university was collecting it. I think Fauci at the NIH is in charge.
It's a very easy way to get it done. If you just Google NIH convalescent serum, basically it'll take you to the website. And the way that it works is you email them. They will reach out to you if they want to enroll you. They're picking people in different parts of the country at certain numbers. If you get contacted, you read the consent form, you sign it, they mail you a device, basically do a finger stick like you're checking your blood glucose, put it on a blotter, send it back to NIH, and then they'll tell you whether you're immune or not.
That's awesome. And I could tell you, I just donated blood a few weeks ago at the American Red Cross.
2 weeks ago.
And 2 weeks ago. And they do not test your blood for coronavirus.
Yeah.
And the reason why they're not doing that right now is you have to have symptoms. They're taking your, to see if you have a fever and that sort of thing. But back in the day when we had SARS and MERS, they would screen the patients the same way, and there was no transmission of those diseases when that was happening. But that's where we are today, and that's what's happening. They are now wearing masks. They weren't a couple weeks ago when I went. And every 2 seconds, somebody in the U.S. needs blood. So that's how desperate we are right now for blood. So if you're healthy, that's a super cool thing to do. But now we're just going to kind of tune things down a bit and get a little less doctory, maybe a little more holistic, and watch these two roll their eyes on me. I just want to get back to your house, your home, your family. And if you go to the CDC website, I mentioned this a little bit the last time we chatted. There's a definitions for methods of cleaning to reduce the risk of spreading infection. So when we clean surfaces, we're removing germs by using like soap and water, and it kills some of the germs. Disinfecting, we kill germs on surfaces and objects, and we're using chemicals to kill those germs. And then sanitizing lowers the number of germs on surfaces and objects to a very safe level judged by public health standards, which means it kills 99.9% of the germs. So there's certain products that will do this for us. Oh, I love that. Thank you for pulling that up. If you go to CDC website, they'll shift you over to the Environmental Protection Agency. I just wanted to remind everyone, some of these products, make sure you're reading labels, because as soon as you use them on the surfaces, it doesn't mean that it instantly works. There's what they call a dwell time. So the products need to stay wet on these surfaces for a certain amount of time. So some of the approved products, and I'm not going to name all of them, One of the best things to do is make your homemade bleach solution. Dominic, how much bleach per water? You should know this by heart now. 1/3 cup of bleach to 1 gallon of water. And let that solution sit on your surfaces for 2 minutes to kill germs. Now, as I'm saying this, bleach is not safe to use on every surface. So you don't want to trash your like fabrics and stuff like that. Again, read the labels what you can and cannot use on certain surfaces. Lysol wipes take about 4 to 10 minutes. Clorox wipes 1 to 4 minutes. Hydrogen peroxide 3% undiluted on a surface will kill germs in a minute. 70% alcohol, 30 seconds, no dilution. And then there's a Microban and Purell multi-surface, and those clean things pretty instantly, but obviously those are kind of hard to get right now. Some of the things to avoid, because there's a lot of myths out there and we just don't have enough evidence. People were using vodka to make like hand sanitizer and to clean. Vodka, even though it says it's 80% or 80% proof,
No, 80
there's
proof.
80 proof. There's only 40% of actual alcohol in the product.
So my dad worked for a liquor company his whole life. So I learned early on that proof is, if you're 100 proof, it's 50% alcohol. If you're 80 proof, 40%. If you're 100, 151, 75%. All right. So
that'll work.
Oh, did you guys?
That'll be close to working.
Why I brought up on camera, you guys started talking about booze, and I just
whoa,
I mean,
the house is full now. We're
It was time for a toast at that point, I think. Right,
yeah, but,
Dan?
I mean, when you get to proof, you cut proof in half. That's the alcohol content.
Oh my gosh, 151. Do you remember like Harry Buffalo parties in college?
Yeah. Right.
Anyhow, so vodka's not going to work. Vinegar is not going to kill the coronavirus. Typically, vinegar is okay for some germs and washing produce, but not with this bug. There's a lot of controversy out there right now about UV lamps, and there's just not enough evidence. And there's different types of UV lamps. You would need a UVC type of lamp to disinfect the air, and some hospitals use that to disinfect the air. But according to the WHO, UV rays are harmful to human skin cells, and we just don't have enough evidence. Saline solutions, not going to cut it. Just a reminder, areas to clean, you want to do high touch areas, tabletops, countertops, doorknobs, light switches, keyboards, our cell phones, faucet handles, toilet handles. And when you're doing laundry, Mike, I'm going to talk to you about this. Let me save this point for the end of this. Don't shake your laundry, because if there is like any germs on there, you're just throwing it into the air, and it will release the virus before you clean it. As you're getting it into the washer and dryer, or ripping off the sheets off the bed, just kind of do it, in a nice manner. Your water from your hot water and your dryer will kill the bugs. Our dryers heat up between 135 and 150 degrees Fahrenheit. And don't forget to wash your hands after you wash the clothes, or put the dirty clothes in the washer, and disinfect your laundry hamper. So you could do that by steaming, spraying with Lysol products, or just washing it down. Mike, the CDC had on it to wear gloves while you're washing clothes. And there's just so much controversy about people wearing gloves, especially grocery shopping and stuff, because the germs adhere to the gloves. And this is no offense to lay people, because 30% of people that work in the hospital do not know how to don and doff isolation stuff. So putting on and off the gloves, mask down. They did a study, and 30% of the hospital folks even got it wrong. So I do want to ask you about that, and not save that until the very end.
Yeah, so I'm very anti-glove for most people. It's great for us in the hospital. We do a good job of washing before and after putting the glove on. Whenever they get contaminated, we change, supposed to change, I do. But I think the big thing is there's nothing magical about a glove that once you put it on, you're protected. There's no difference between the glove and your skin. The one difference is that people think they're protected, so they're less careful. They don't wash their hands as often when they're wearing gloves. So again, I'm not a fan of gloves. I'm a fan of washing your hands. Hand sanitizer is great, the alcohol-based hand sanitizers. And again, there's a million recipes. Ken made our own Everclear and aloe gel. And that works great. You can make as much of it. Again, Everclear was probably more expensive than rubbing alcohol, but more available. And then was easy to get as well. It's almost as good as the Purell.
Tastes better.
That's true. And you can drink it. Although I don't recommend that. So I think washing your hands is important. I think when washing your clothes, if they're your clothes, I'm not as worried. It's just more important. Put them in, wash your hands, and be done.
Well, this poor guy doesn't stand a chance. He's not allowed to wear shoes in the house. By the way, this bug can travel on shoes. And they went to areas of the hospital and swabbed pharmacies floors. And so there's no patients there at all, right? No positive patients there at all. And this stuff is traveling on shoes. So either have a designated room, like our laundry room, but this guy, since he goes back and forth to the hospital, they stay out in the garage.
True story.
So,
and it was 32 this morning when I walked out the garage in my socks.
And he's only allowed to wear, he has one designated pair of shoes that he goes back and forth to work with. Everything else is put away on lockdown.
Then I change clothes in my office and go to see patients. So I don't bring anything close home, but I'm not allowed to do anything until I come home and change.
This place is shut down. So this is how crazy I'm getting. So the best defense always is hand washing. Whether it's your best defense, whether you're grocery shopping, trying to figure out if things are dirty or clean, whatever. Whenever you eat, cook, just wash your hands. That's our best defense, right? We saw that lipid fat layer that encapsulates the virus. This busts through. You've seen how dish soap goes through grease and like a butter dish, how you can clean a butter dish. Same thing. It will bust right through.
It breaks up with the bilayer.
Right. So then I've taken it a step further. We have an air purifier. If you want to know more about that, just, IM me or something. But it clears out not only cigarette smoke, pet dander, allergens. It gets rid of a lot of bacteria and viruses too. There's 4 different filters for that. And I also invested in a really cool steam cleaner. It's a great green way to clean your house. The water heats up to 200 degrees Fahrenheit, and it's wonderful on wood floors, tile floors, showers, everything. Everything gets steamed around here. Rugs, curtains, fabrics. You can even clean your grill out in the backyard. It's got a lot of attachments and stuff, and I'm happy to tell you more about that later. And then I already told you about the laundry bin. Don't forget to make sure you're cleaning that and doing your laundry as frequent as possible. There's controversy whether or not you should use a little bit of soap when you wash your produce. I give my produce a bath and I just put a drop of soap in a tub of water and wash everything down. If you have antibacterial soap or harsh soap, I wouldn't use that in your bath. I use 7th generation. That's personally what I'm doing here. I'm not making any harsh recommendations. I don't want anyone to get sick. The FDA cannot endorse this because, it hasn't been tested for like human consumption. But if you just do a quick little bath, little rub, friction's great. Don't forget heat kills this virus too. And then a great rinse and then, let it dry. That's what we've been doing. Hey, you two shut up. I see you on the corner of my eye. And then we have a lot of little free libraries. I wanted to ask you about this. This is on my mind. This is why I don't sleep at night. So they're really cute, these little houses, and they're all around the neighborhoods, and people are putting paper books in and out, and
it's a free lending library. Yeah.
It's really cool and a great concept. But I'm thinking that should be shut down right now. We should probably not be sharing books. What do you think about that? I know you think I'm crazy.
No. I would say there's no way to really clean the books, so just leave them in the. where you pull out your Kindle, download the book, and
Yeah. Well,
skip the little.
And then wipe down your keyboard. Okay.
Yeah,
I'm avoiding that stuff right now. And then the last thing I just wanted to touch base about is a lot of people have professional house cleaners. So when house cleaners are allowed to come back into the environment, and maybe we're doing a spring cleaning or something, really do a thorough job of watching what type of equipment they use, ask what type of disinfectants they use. Are they sharing equipment between homes, vacuums, and that sort of thing? We are locking down here. They're only going to use my equipment. Nothing leaves, nothing enters. But that's what we're doing.
That's how PJ rolls. Okay.
That's how I roll.
I'm more afraid that they'll be sick and come into the house. I'm not as worried about their cleaning supply. So we've, for now, unfortunately, had our cleaning lady not come in. My cleaning lady is Ken, so.
I'm the cleaning lady here. Yeah. me and the steamer. All right, so now we're going to focus over to Dan and Dom to look at a little bit at pandemics and how they've impacted the housing economy. And we're going to touch base on that. And then after they're done, Mike, I have a list of questions to ask you, and then we'll kind of wrap things up.
Very, very cool. Sounds.
Thank you guys very much for doing this for us. We really appreciate it.
Yeah. I'm pretty sure they can still. Will you guys nod your heads? Because I know, Dom, you can't see them, but will you still nod your heads if you can hear us? Okay. Yep, they can. So just FYI, if we make fun of them, they're there.
They're there. Okay, deal.
Yeah.
No, thank you guys very much. That's awesome. I got text messages throughout the entire thing. We have surgeons from the West Coast all the way to cashiers on the East Coast. Every demographic covered on tonight, which is really cool.
Neat. Very cool.
Yeah. So thank you guys.
Did you want to start things off? I think you do you kind of have an idea where you want to take things first? I've got some of the stats and some of the other slides too. So
yeah, so we had just 4 things we wanted to show you guys tonight as far as it impacts the real estate market. So and not necessarily tied to real estate. Most people are worried right now about stocks and bonds in their portfolios, and then other people are worried about their second biggest asset, which is typically the home that they're living in, or investment properties as well. So one of the things hyper local here that we're seeing in the city of Madison, more specifically Dane County and our MLS, is still the need for inventory and still the need for buyers. So as we closed out March, when this started to happen, we're still ahead of last year. We're anticipating the same thing for April, and we're anticipating a later shift in the spring market this year. So we're anticipating more purchasing happening in the summer and the fall this year than it typically would. So
yeah, one of the things to know in regards to this as well is just that while the numbers of actual closings and everything are kind of relatively staying the same, one of the things we can report internally from over 115 agents, showing a lot of houses, we do a couple thousand transactions a year, and the showings are way down now. And one of the reasons, though, isn't because we have less people. The demand has stayed extremely high, but the inventory that normally comes on in a rush in the spring because of simply this in our area, in addition to the fact that it is a cyclical market, it's a seasonal one. And of course, the COVID virus has planted itself right in the middle of the spring market. The positive to look in that comment or in that little line, though, is that builders are obviously out building, and they've knock on wood and pray to whoever you pray to that they continue to get some decent weather and we don't get too many of those nasty storms like they had down south, and everything else, because we need buildable good days. But we are really looking at a lot of pent up demand, are we not? I mean, that's what we're hearing around the horn. So these numbers are likely to go up, but the demand is still there. So
Yeah, and that's what we're continuing to see as well, specific to Dane County. So when we look at our area, we have a really good diverse workforce in Dane County, which I think is continuing to show that demand. Now, when we expand it out to those other slides, Dan, and we look at the nationwide perspective, I took these slides and these statistics to try to align them to what's happening with what Mike was talking about earlier, and Mac and PJ about the SARS and the MERS. And
I'll bring that one up first, and I do apologize. The gradient is going to be a little off, but we're, as far as whatever, but it'll still be there.
Cool. So if we look at that one, we can see 9/11, the SARS, and the H1N1, and the impact on housing. And really, most people worry about housing because of what happened in 2008 and 2009, which is rightfully so. And when you look at the impact here, really no impact due to those. I think what you saw today in earnings, if you're watching CNBC or any of the earnings reports that came out, we had major banks report earnings today. I think we're seeing the steep dip, and Goldman and JP Morgan are anticipating the same type of recovery, the best recovery we've ever had. So that's coming from the banks. That's not coming from any type of like political slant on that.
Well, and let's face it too, guys, like one thing that everybody focuses on in any sort of a crisis or any sort of like obvious negativity that comes in the media is it's the hyper focus on what's happening next versus what was happening leading up to this crisis. And I think that's really an important part of this conversation too, is everybody wants to say, well, last time or this last time or this last time. Well, if you look back in history, every housing or financial downturn was predicated by some things that were coming. They were long-standing coming, and then like after the crisis, they could point at those things and go, "See, this was happening." Well, we didn't have anything negative in the lines of statistics happening before this virus hit. So there isn't really a reason to say that other than the virus damage itself, which might be counteracted by an extreme amount of demand, and we just don't know. The amount of money that's out there is still quite high. So, and Dom, which one did you want after that? Sorry.
Go to the one that shows the spike in poor loans. And I think it's really important to tie that back to what's happening in the market right now. What banks are doing right now in the market from an economic standpoint is smart. It might not seem fair that, standards are heightening and credit is tightening in certain areas. JP Morgan's a big one. Their standards and their
and just because this will be hard for everybody to see on there or whatever, this starts in June of 2004. This is June of 2008 all the way through today, just to give everybody kind of a.
So when we pulled the statistics and we were talking to agents from multiple brokerages throughout the entire country on Monday is when we got some of these statistics, and we were talking about what's happening in different markets. Housing bubble was due to bad loans. If you look at that today, the banks are reacting the way we need to react. Anyone who is maybe a low credit score buyer or someone who might be a low down payment buyer might have to wait. And that's the reality of the situation right now. We're in a market where we're fortunate enough, real estate is considered or deemed an essential position. And we're still seeing lending happening. We're still seeing, in our area specifically, that same demand there because the inventory has been so tight and Madison's a booming area.
Yeah, and can I mention something too, Dom, since you touched on the fact that it is an essential thing, because I do know there is certain things going on too. Like nobody would dare shame the great two doctors or nurse that were just on speaking for continuing to do their profession or do their industry right now. But there is a little bit of that going on in ours, and it is a great opportunity for us to remind everybody that we're not out slinging sales for our clients. There are people that actually have to move, and properties and homes too at their core are what we call shelter. Yep. So, and shelter is the part that's the essential part. So I think that's critical that we take this opportunity to mention that, because there are people in our profession and colleagues of yours and mine that some are afraid to go out and do their job right now, not because they're afraid of the virus. They've already been trained on how to pretty much do this with almost zero human contact right up until we have to. And even then, I think we can do it very safely. And yet they're worried. They're worried to go out because they're worried somebody's going to be like, why are you doing your job right now? You're going to get someone sick. And so anyway.
To Dan, I think, Dan, to what your point is, when we're talking to agents throughout the country, we're seeing that markets that are hit really hard, primary business there is not getting people into a home, or they're going to be homeless. Primary business in some of those markets is a high rental market. So because of how people are reacting as landlords to the rental market, people are able to extend leases and shelter in place. And I see one of the questions coming across the screen right now about shelter.
Oh, yeah.
I think in our area, we don't have the convenience of letting people say, hey, you can't close on your home, because then you have nowhere to go, because of the ripple effects that makes in our market specific to Madison, because we aren't a high rental market like a New York City or a Chicago or a San Francisco. However, when there are smart ways to do it. So my clients that are in a high risk category and wanted to show, I've told them absolutely not. We're not doing it. It's not responsible to do that. My vacant homes, there's Clorox wipes, there's hand sanitizer, there's gloves, there's disposable booties, and there's a trash can by the door. So there are smart ways that we can continue to conduct business for people, and at the same time, keep up with making sure people have a place to go once they close.
I want to be cognizant of our live audience a little bit here too, because we had Josh Fisher, he's like the data points on that. What is that last graph? And I just wanted to point out to everybody. So this is Mortgage Credit Availability Index. So
everybody in there, everyone and their mother in 2008 and 2009, including private lenders, had access to capital that was based off of Ninja, no income, no job application, and could get credit for anything. Throughout the years, as more accountability has been placed on the lender and low down payment programs have been placed on the lender, we've been able to maintain high standards, whether you have a low credit score with a low down payment or a high credit score with a high down payment.
And let me be real clear, if we got any of our lender partners out there, that is not Dom blaming the lending situation on that. Lenders were forced into a must-do competition during that period of time as well. And whatever, there was a lot of stuff going on back then. Now, what's the movie, The Big Short?
Yeah, I love it.
I thought it was actually a pretty good depiction. Obviously, there's still some Hollywood in there, but I've got the one more slide here, Dom, with the unemployment rates. Did you want to touch on that real quick?
The only thing to mention there is we're going to see a spike in unemployment right now. That's inevitable. We're feeling it right now. And again, that means that maybe buyers who are ready to buy now are going to have to wait 30, 60, 90, 120 days. There is no correlation with home values and the unemployment rate. That's all.
Right on. Yeah, and I think I would just love to share a personal story really quick. So I just thought it was at least a little interesting. I went over to the Pier 1 market to pick up mobile groceries in Monona there, and I pulled in and made my telephone call, and so the kid was coming out, and I called him a kid because he was young. He told me. I had my mask on, and he came out. He did not even have a mask on. Starts loading it in my car, and I said, how are you doing? And he said, good. And he goes, it's actually my first day doing this. I was a server over there at BW3's. And I was like, oh, yeah, okay. And he's like, yeah, I mean, everybody got canned. This is like the only job I could find. Two things I take out of that story. Number one, he did not give it. I mean, he obviously, like, that virus meant very little to him as far as the fear factor of him being out and being whatever. But I was really happy to see that he had gotten canned because of something, and literally like took a job across the parking lot doing something completely different to go get a job. I mean, that was positive. So I don't know. I don't know. Hey, maybe should we can let our the cool people back in. If you guys have comments on anything too, we're done with our are we done with our nerd section? Can we let the nerdy doctors back in?
That was
We have the perfect balance right now of economic and healthcare. It's perfect.
Perfect.
Yeah, that's right.
Because that's out of our wheelhouse.
Yeah.
It's the 10 minutes. It's great. That's right.
Yeah. No, I mean, this was really great. I think, if there's any, certainly any rumors I would like to dispel in both the financial world and everything else is that, everyone's going to look for blame later on this year. It's an election year on top of that. So if you use the social space to communicate with friends, family, or anything else this year, I would just really, my public service announcement for the night before we leave is for you to really be cognizant of that between now and the election time. Do you really want to ruin a bunch of relationships when it's not the conversation between you that's wrong? It's not the relationship that's wrong. It's the platform that you're doing it on, and it's the context of the arguments, and it's the corruptness of our system.
Well, especially when we're living with a life and death situation, right?
Yeah, we need to get the politics out of this. Whoa, where'd we go?
Where'd we go?
For sure. You guys are still there for us. I don't know.
Are you guys still there?
Yeah.
Our computer decided to search for an
This is the
update.
best. This is one of those awesome, cool live Zoom moments too.
All right. I can't see you guys at all, but
You're still there. You look great.
We can hear you. You guys are great.
No, it just said our computer's looking for an update right now. Thank you.
Thank you.
And I can't do this techie shit, so I
We're not reading it.
Dan, I thought swear words were supposed to be filtered out.
sorry.
Oh, hey, YouTube.
We did have
YouTube.
one more Facebook question.
You're back.
You're back.
Hey,
All
guys.
right, I'm ready.
Let's see real quick here. I know some of our streams, so I apologize to everybody out there in online world land. Some of our comments didn't come through to us in this system from some of the different places. I'm going to go on and check the other Facebook feed really quick, but
Dan,
I
there
have-
is-
if you have anything to ask of our panel or of anybody else, and certainly PJ or Michael, Dr. Michael, I hate, it's like when I was in the military, you can't really screw that stuff up much. You get burned up, but you guys don't seem to care. You guys are cool.
No.
Dan, there is one more that came through from a gentleman named John on Facebook. He said there are political forces that are pushing for opening up the economy. It's about halfway up, Dan, if you want to throw that up.
Yeah, I had that one come up a little bit earlier in there. I'll put that on there. I think that's actually a worthwhile topic. We don't need to get too political, but it is.
The second part.
There are political forces that are pushing
strong
for opening up the economy. What would be a strong indication that would be safe in your guys'
I think that's let's avoid all politics, and we did that last time too. It can get ugly.
I think you could answer this in a medical way.
The
let
safety
Michael
part.
take a stab
Yeah,
at it, and
go ahead.
I'll give you my thoughts. But
The second half of the question is critical.
Right.
Okay. So again, I think the way that I would think about it is that I showed you that graph in Seattle when the number of secondary transmissions gets below 1, that's when I think it's relatively safe to open. Whether you could open a little sooner than that in some areas, I think sounds pretty reasonable. And that kind of data is available in a relatively granular bit of data. I think some of the things that have been also outlined, making sure there's enough testing capacity, hospital capacity, and whatnot, so that if the numbers start going back up, you can recognize that and deal with it, I think are also critical components to any decision.
and I think that most healthcare
I'm not sick.
most
Thank you.
healthcare systems understand that this isn't a black and white, yes, no, light switch decision to start the economy. It's not like we're going to go back to instantly where we used to be, and we may never go back to where we used to be. But there are clearly places, and you looked at Mike's heat map of places that are affected, and there's a lot of spaces that are disproportionately less affected. That might be the safest place to cautiously restart, allow some businesses to get back into business, and and see how we do. We have to do it in a cautious way, in a safe way, and monitor. So I'll give you a local example. Unfortunately, we had an election here last week, and we all went to the polls.
Yeah.
And I think most of us in healthcare were ticked off about that decision. There's no reason for politics to enter this viral thing. So we're all going to be a little interested in what happens in another week or two when we get 10, 14 days beyond that to see what happens.
Yeah.
And whether we suffered, some bad consequences of in my opinion, a stupid decision. No one was going to lose their job over whether we went to the polls that day or not. It was a primary election. So in any event,
Okay.
Enough politics. But
Yeah.
at the end of the day, I'm going to steal the American Lung Association's tagline, but if you can't breathe, nothing matters.
If you can't breathe, nothing matters.
And that's not my line. That's their tagline now. But I'm a big supporter of the ALA. So, I mean, we want to take care of each other and ourselves. So let's do that.
Let's do it. Great. So, Mike, I have some questions here for you. So you're going to be back in the spotlight here.
Okay.
Why is this virus called a novel virus?
So the reason why it's called novel is because it's new. It's not been seen before. So it's new to everybody.
Okay. And some of this stuff I'm pulling right off of some myths that may be spreading on social media. So even though some of these questions sound a little bit out there, it's because I'm trying to bust some myths that are out there. So is this virus caused by bats? And are there other viruses that were caused by bats?
Yeah. So the virus is related to a bat coronavirus, and when SARS first happened, it was felt to be related to a bat coronavirus. There was a lot of work to look at coronaviruses in bats, and there's literally hundreds of those viruses in bats. What we don't know is what made this get into humans and then transmit so easily. But it is related to a bat virus, probably got into some intermediate animal that then affected humans. What that animal is, there's some theories, but not been proven.
Gotcha. And there's a lot of conspiracies out there, but maybe that's another night, and we may need to do like an edible or smoke something before that conversation. All right. So the next question is, can saline?
This was not moderated for that kind of stuff. I'm just saying.
Oh, sorry. I take that back.
She thought she was living in Colorado.
I thought I was talking to Mike.
We are in Madison.
Can saline nasal spray kill the virus if you spray? Okay. What about, I heard aiming a blow dryer, the heat from the blow dryer, if I aim that up the nasal passages or oral areas, the heat will kill the virus. Is that true?
Nope, not going to help you. It would need to be so hot you wouldn't have a nose anymore.
Okay. And then we already talked about wearing gloves when we're shopping and why we shouldn't be wearing gloves, and just practice really good hand washing. Can someone get the flu and coronavirus at the same time?
Theoretically, yes. And looking at the data, there are some people that have the novel coronavirus or COVID-19 and another virus. Looking at the data at our hospital, it's only about 1.5%, so relatively infrequent. It was seen a little bit more in China because there was more flu in the area as well. So it can happen, just not very common.
Okay. So the next question is, I don't have an N95 mask, and I'm going out with a homemade mask that I made. And I know that this mask can't protect me from certain viruses, especially this virus, because it's porous and it can get through. Why do I have to wear a mask at all?
Well, the mask does a lot of things. Number one, it prevents you from touching your mouth and nose, so it sort of helps protect you there. It does help against droplets coming in. So it does actually help reduce the risk. It doesn't get rid of it completely. Those would be the main two reasons why it's beneficial. even though it's porous, even the N95 is porous. It's just that it's designed so that even tiny things can't get through it. So you do get some degree of filtration from even a homemade mask.
And then is it true, like maybe I'm an asymptomatic carrier and that will prevent me if I cough or sneeze or something to spread the virus to?
Definitely will help
or landing on my apples that I give baths to.
Exactly. Yeah. When you're feeding the bats.
Yeah. Okay, good. All right. So tell me about what is herd immunity and how long do you think it will be before we can expect that?
Yeah. So herd immunity is when you have enough people that are protected or have antibodies to an infection, so it's less likely that when a sick person comes into a room or a space that they can transmit it and get a large number of people sick. Typically, you need somewhere between 50 and 70% of the human population with that kind of antibody or prior exposure to have herd immunity. And when that happens, it just markedly reduces, if a sick person were walking around and everyone's immune, no one's going to get sick and there's not going to be a big outbreak. But if only one person is immune and you're in a room of 20 people get sick, they go on and infect other people too.
Okay. And then should healthcare workers self-quarantine at home from family members in case they are silent carriers or they've been exposed, but maybe like how?
So that's a loaded question, Michael, because this depends on where I'm sleeping tonight.
As I say, if you want to self-isolate, that's your own decisions. But the reality is it's not actually recommended that people that are healthcare workers self-isolate from other individuals that are healthy. I think if you had an elderly or debilitated person living in your house, if you had a transplant patient in your house, I think you'd want to be extra cautious and maybe try to keep 6 feet away from that individual. But really, for usual healthcare, the way that I look at it is I'm far, far more worried about catching COVID-19 going to Whole Foods than I am going to the COVID ICU in the hospital.
Interesting.
It's, everyone's wearing a mask in the hospital. Everyone's being careful with hand hygiene. People are, I think, more thoughtful about being safe and covering their cough. You walk into Whole Foods and it's everyone's doing whatever they want. You don't have everyone in a mask. Some people are picking up every apple and putting it back down. I don't know. That's my
So 2 things are popping up here on the screen. Can you be influenza A positive and have COVID-19, worst flu of 10 people's lives? Could you have already had the high fever, etc.?
Yeah. So generally, it depends on when you got sick. If you had it before probably the end of December, beginning of January, it was flu. It wasn't COVID-19 in the United States. If it's been after that, it could have been flu. We had a late flu season here in the United States, or it could have been COVID-19. And again, I think it would depend when you got sick. If it was January, more than likely it was flu. If it was last week, it's more likely that you had COVID.
Got it. And then we have high risk isn't just 60 plus. Who else does it influence? Cancer, pregnant, chemo, etc.
Yep. So it's kind of interesting. Definitely any underlying medical condition, cancer definitely is associated with a higher risk, including patients getting a recent chemotherapy. Pregnancy, unlike most other viral infections, actually doesn't appear from the data that we have to date to significantly increase the risk. And this may be in part because people are younger when they're pregnant, but unlike flu and other viruses where mortality is higher, it actually appears that mortality, if anything, is the same, if not a little lower than non-pregnant.
Okay. So we've had SARS, MERS, H1N1, Ebola. The world didn't shut down for that. Why, for this virus, are we shutting down?
Yeah. So I think that for all of those, you were able to do containment a lot better. So we didn't have the number of cases spreading in the United States like we did with those prior illnesses. And particularly, if you look at SARS and MERS, we didn't shut down in the United States, but Hong Kong shut down for SARS, and much of Saudi Arabia was shut down for a period of time when MERS was first emerging in 2012. It really it has to be calibrated to what's going on locally and how many cases you're seeing. With SARS and MERS, we literally had thousands of cases globally, not 2 million.
Got it.
With the world shut down.
So the question just popped out: is the mortality rate lower with more testing? I think the current wisdom is yes. The more people you test, the more minimally or asymptomatic illnesses you'll detect. And what we're really talking about is the case fatality rate, the number of people who die over the number of people who are diagnosed. What we really don't have a good handle on right now is the number of people who are diagnosed.
Yeah.
And that's why a lot of times people will look at mortality rate instead of all positives, but maybe of patients admitted and diagnosed in the hospital.
That's originally dominant.
Mike, will you swim with me in Lake Mendota this summer?
If it's warm enough. If it's warm enough.
That was Dom.
If it's warm enough. That's definitely Dominic.
So,
all capitals.
We're gonna wrap things up. We don't want to bore too many people here. Again, thank you, Dan and Mike and Mac. And if anybody's looking for healthy home cleaning tips or anything like that, just connect with me. I'll let you know what I'm doing here. And thank you for joining us.
Yeah. I will certainly, down in the comments of this live post, I will throw down a link over to Dr. Mike's stuff in Northwestern. I'll throw a link out there for Heal Garden, and of course, a little website, or if you want to get to me and Dom on Facebook or Instagram, it'll be easy to find. Dr. Mac, thank you. Dr. Mike, thank you.
Thanks.
PJ, thank you so much. Dom,
Thank you.
Stay well, everybody.
have a wonderful, wonderful night. Thank you so much.
Thank
Bye,
you.
everybody.
Thanks, everybody.
Bye-bye.
Thanks, Mike.